Welcome to Verified RX, your prescription for success. Brought to you by the Vizient Center for Pharmacy Practice Excellence.
Recently, there's been a lot of interest generated by a new FDA approval. Suzetrigine, Journavx, was recently approved by the U.S. Food and Drug Administration for the management of pain. Although there's a lot of excitement about having a new tool in the toolbox, there are certain limitations that are important to consider. Here to talk about this is Dave Peterson, pharmacist and drug information specialist with the University of Utah Health. I'm Kerry Schwarz, pharmacist with the Vizient Center for Pharmacy Practice Excellence, and your host. Dave, thank you so much for joining us today. There's lots of information out there about Suzetrigine, brand name Journavx. Tell us about it.
Thanks, Kerry. I'm excited to be here. This is a new non-opioid analgesic. It's labeled for treating acute, moderate to severe pain in adults. And it's actually the first oral non-opioid with a brand new mechanism of action that has been approved in over 20 years. So it's exciting for us. Some things about it that are important. There's no euphoria associated with it. At this point, no evidence of addiction or dependence potential. Looking at that with the lens of the opioid epidemic, we're looking for treatments that can either replace or reduce the use of opioids in specific scenarios. We're not out of the woods on the epidemic. It's still a big concern. We have seen some numbers improving recently. Opioid prescriptions have really drastically reduced over the last 15 years, but there's a lot more use of illicit opioids. Opioid overdose deaths have fallen in the last year and a half, so that's great news as well. In the realm of the opioid epidemic, interested in anything we can use to reduce our reliance on opioids. We've seen, because of the opioid crisis, a relative undertreatment of pain. Maybe patients aren't being treated quite as aggressively for pain as we did in the past. One of my concerns with that is an increase in chronic pain. We're seeing the prevalence in that increasing, and that is a big burden already. Having another thing to treat pain is really exciting for me to see where this takes us and how this helps us to better manage people's pain.
Yeah, we're always excited to have another tool in the toolbox, especially when it's something novel like Suzetrigine. So you talked a lot about non-opioid treatments for pain. We already have some non-opioid medications for pain: gabapentin, pregabalin, the non-steroidal anti-inflammatory drugs, and even duloxetine. So what distinguishes Suzetrigine from the rest of those non-opioid analgesics?
As you talk about all of those different non-opioids, the context to remember as far as pain management is concerned is we're very interested in using multimodal management. That means using drugs of different mechanisms of action, using those together to better treat pain, hitting it from multiple sides at the same time. And so you do have a lot of different drugs with different mechanisms of action, but this one's brand new. It is a selective NaV-1.8 receptor blocker, a sodium channel blocker, and it mostly works in the dorsal root ganglion. There is some work in the CNS, but a lot of it is peripheral. As far as the mechanism, if I were to describe it similar to something we already have, it is lidocaine, bupivacaine, carbamazepine, phenytoin. Those are all sodium channel blockers. But we have limitations with using any of those agents at high doses systemically because they have a lot of toxicity. The main difference here with Suzetrigine is it's selective for the NaV-1.8 channel. That selectivity for that specific channel seems to be important in reducing the toxicity, but still providing pain management. It's not that it's going to replace anything else. It's a matter of having another mechanism of action to be able to hit pain at the same time as these other things.
Isn't there a difference in what Suzetrigine is indicated for? It's indicated for moderate to severe pain. Is that the case with all of the non-opioid analgesics?
Very good point. NSAIDs, a lot of our OTC things, acetaminophen, ibuprofen, naproxen, those are more for acute, mild to moderate pain. Oftentimes, those could be used alone as monotherapy. As we get to more moderate or severe pain, we're looking more at multimodal, using multiple agents to treat that pain. And so this does have an indication for moderate to severe rather than mild to moderate. And then thinking about things like the gabapentinoids, being gabapentin and pregabalin, those drugs are primarily for chronic pain. We do have more data on them, using them acutely around surgery and potentially having some benefit there. But in general, they're more focused on chronic pain, whereas this has a little bit more of a mechanism of action angled towards acute pain. Now, it may also have a role in chronic pain, and that's actually currently being studied.
You talk about how it's being studied. We've got Suzetrigine. It's novel. Sounds like it fills a needed niche in therapy. Let's talk a little bit about how it was studied, because the FDA does have a certain approach and a certain framework that they have that they like for sponsors to use when gaining approval for analgesics.
You're right, Kerry. A lot of that has been laid out in the Support Act, which has really promoted alternatives to opioids. FDA released a guidance for industry talking about how to study acute pain. That lays out what types of endpoints you need to look at, what types of studies you need to perform in order to get that FDA indication. Sometimes we get a little ahead of ourselves and we don't think about the fact that FDA has very specific study designs that they like to see in order to get approval. With Suzetrigine is we have that approval, we have those studies that were based on the FDA pattern, but maybe those studies don't answer all the questions we have at this point.
Absolutely makes sense. Talk a little bit about the surgical models and the endpoints that we commonly see in these studies.
Looking at that and thinking back to our conversation about other pain medicines, there is one important difference that we need to point out about Suzetrigine, and that is that it's not a PRN or as-needed pain medication. It's a scheduled pain medication because the onset of action is delayed about 2 to 4 hours after you take it. It's not something where if you have breakthrough pain, you're going to take it. It's important to think about that as we look into the studies. This is a scheduled med and not something that we're waiting for the patient to have pain and then treat that pain, because the onset is so long. Approval was primarily based on 2 phase 3 post-surgical pain studies published in a joint publication. The first one was called NaV-igating. It was a study in bunionectomy. Second one was NaV-igating, which was in abdominoplasty, or in common terms, tummy tuck. Both of those are really common models for pain. They're both painful procedures. They're commonly used for new pain meds. Both of those had placebo as a primary comparator. Suzetrigine was given scheduled. And then there was, in addition to a placebo arm, second comparator arm, which was hydrocodone 5 milligrams plus acetaminophen 325 milligrams, and that was scheduled every 6 hours. A little different than sometimes we see our opioids. If we're going to use them scheduled, it's generally a little bit higher dose. This is probably about half the dose that I would commonly see. PRN use would be a little bit more common in this type of surgery. So it was placebo, Suzetrigine, or the hydrocodone acetaminophen combo. Patients in each group could also get ibuprofen 400 milligrams every 6 hours if they needed that for additional pain control. In these 2 studies was that 70 to 80% of patients in the Suzetrigine group did require the ibuprofen. In the real world, they probably should have had a scheduled ibuprofen or something in the background and then added the drugs on top of that to ensure appropriate pain management. Those are the 2 main studies. In addition, there are also 2 phase 2 studies in bunionectomy and abdominoplasty, and there are a couple off-label studies that have not been published at this time. One was a phase 2 study in painful diabetic neuropathy, and then there's also a phase 2 study in low back pain, which is unpublished. And in those results, the Suzetrigine came back as being similar to placebo in the response that it provided.
What I thought was interesting is that there were some mismatches between the studies, that some results were inferior, some were equivalent, and others, there weren't statistics, but it appeared to trend better. How can we make sense of some of these discordant results overall?
The main pain measurement used in these studies was a summed pain intensity difference at 48 hours. Essentially, you're taking a numeric pain score at specific intervals and comparing all those against baseline to see over a 48-hour period how much is your pain lower or higher than it was at baseline. There were similar results with Suzetrigine in both of these phase 3 studies compared to placebo, and Suzetrigine was superior to placebo in both of those. That shows us that it is functioning better than placebo, and some pain studies just taking anything, even a placebo, does provide some response. Improving beyond placebo is a good thing, but we did see differences when compared to hydrocodone acetaminophen. And in the bunionectomy study, hydrocodone acetaminophen was actually superior to suzetrigine. And then in the abdominoplasty study, the pain response was very similar between suzetrigine and the hydrocodone acetaminophen. It's unclear what the reasoning for those is. It a matter of soft tissue surgery versus orthopedic surgery? What is it about those that is different and made suzetrigine perform differently compared to hydrocodone acetaminophen? In the real world, we're probably not going to use them this way anyway. It's probably going to be used in combination with other medications. It's an important trigger for us to watch and realize that not all patients or not all surgeries we're going to see the same results for suzetrigine.
Agree 100%. You bring up a good point about the differences in the surgical models that were used and how this translates into the real world. This was added to your formulary. So can you talk about moving now beyond the evidence and actual utilization of suzetrigine and what that's going to look like and what we're looking for?
At our institution, it was approved. There are no restrictions based on service line, but we are going to be doing quarterly MUEs to look at use and figure out, is use appropriate? Some institutions may find it useful to have specific use criteria or restrictions. When we think of the real world, we have data for 2 fairly minor surgeries. We treat a lot of patients that are a lot more sick, that are going through much more complicated surgeries, a lot of different types of soft tissue, orthopedic, all different types of pain. And we're not sure how this is going to work yet. And we really don't have any data in a multimodal model for pain management, which is how we're generally going to treat these. In most cases, we're going to give you scheduled acetaminophen, scheduled NSAID, unless there's a specific reason not to do that. We would also add on either as needed or scheduled opioids, depending on the pain severity. We don't have data on that model. We have data on suzetrigine all by itself with adding ibuprofen for rescue, and most patients needed that. Real world, it's hard to say where exactly this is going to land, but I think it's hard to not give it a try. And it's exciting to have another thing in our toolbox.
You mentioned some really good points there about the real world. How are we going to look at this within enhanced recovery after surgery or ERAS protocols? And what outcomes are we going to measure beyond just simple utilization? For example, picking up the prescription at discharge, continued use after discharge. One thing to think about is cost. It is approximately $15 per tablet. Can you talk about how that factors into real-world utilization?
The cost, when you look at it for a single patient and for a short-term surgery, is fairly reasonable, but cost is definitely something to think about, especially if you're at a place where you have a very high volume of surgeries. You can very easily get to the point where you're spending more than $1 million a year on this agent. So I wouldn't call it low cost. My biggest concern related to cost would be more about waste than the cost itself. If you have someone coming in for an outpatient surgery and you give them a dose of this and you give them a prescription, and then they get to the outside and their coverage doesn't cover that and they only take that one dose that you gave them, I don't know that that's a great model for pain management. You want to be seeing if your patients have coverage for this before you start them on it if you can. There is a copay card available that does cover up to 2 30-day prescriptions per year, qualifying patients. We talked some about the No Pain Act as far as internal costs. You guys have already had a podcast on the No Pain Act, so I'd send listeners to that to hear more about that. But the No Pain Act does provide separate reimbursements through Medicare to help cover innovative non-opioid treatment. Suzetrigine meets the letter of that as far as it's appropriate. It would fit within that framework of No Pain Act, but it got approved in late January and missed the cutoff for the 2025 deadline for No Pain Act. So it won't show up on the No Pain Act, and at least until 2026, there is a chance for like off-cycle review, but it's kind of unlikely.
We've talked about the studies, cost, real world utilization, but there are still lots of questions unanswered. Looking forward in terms of clinical concerns, what are you going to be keeping your eye on?
For one thing, side effects. Adverse effects were quite rare in this. Most of the side effects did occur in less than 2% of patients, were very similar to placebo. So I'm interested to see if additional adverse effects show up as we actually give this to patients in the real world setting who might be sicker or in different situations. I'm also interested to see how it does in more complex surgeries. Bunionectomy and abdominoplasty are quite painful surgeries, but we do have some other painful surgeries that may be more complex. I've mentioned multimodal pain management a lot. If we add this on to acetaminophen, does it provide additive analgesia? Does it provide more than that? Synergistic analgesia? What does that look like when we add it to other things? In the face of the opioid epidemic, we have a certain amount of undertreatment for pain. The pendulum has swung to the point where a lot of providers are hesitant to prescribe opioids. And my concern with this is, will providers completely eliminate opioids as an option for their patients? Will they see this as replacing opioids? I am afraid that if we start removing things, those analgesic outcomes won't improve. In my mind, you would add this on, still have opioids available if necessary, but hopefully this would reduce the amount of opioids that we need to use. We have data in using this instead of opioids, but not in combination to see if it reduces opioid use when the two are used together. I'm concerned would be long-term effectiveness. This has been used in an acute pain model. The maximum duration at this point has been 14 days. So what about pain that persists longer than that? And we don't really have data at that point. There's no restriction. The package insert doesn't say you have to stop at 14 days. Generally, acute pain will be resolved by then. In reality, this is probably not just going to be restricted to acute pain. A lot of that will depend on what coverage looks like, how much patients have to pay, but I suspect that it's going to creep into some of these other pain types where there is a lot of need for additional agents.
There's definitely a lot of potential for off-label use. What are you excited about with the advent of Suzetrigine?
I am super excited that we have a new mechanism of action. We have one more thing to put in there, and I'm very, very hopeful that this will be used in a way that reduces unnecessary pain. Pain doesn't help healing. Yeah, it's normal to have pain, but that pain should be well controlled. That having it well controlled helps with the healing process. It helps with reducing the risk of developing chronic pain. I'm hopeful that this does reduce our reliance on opioids. I'm excited about that opportunity that maybe we can cut down opioids without reducing the amount of analgesia that we provide. I'm really excited to see results in other types of pain. We have seen not so impressive results in low back pain, but we have seen good data as far as phase 2, and phase 3 will be conducted in more of a neuropathic type pain models. And I'm really excited that we haven't seen a lot of adverse effects. It seems to be well tolerated. It seems to be something the patients would be able to take without adding to the side effect burden.
To be continued. It's just the beginning of our experience with Suzetrigine and more to come. Thanks, Dave.
Join us for more Verified RX podcasts. Subscribe today. Like us. Send us your comments. We'd love to hear from you. Verified RX is a prescription for success and is brought to you by the Vizient Center for Pharmacy Practice Excellence. Thanks for listening.